new doctor. My name is EshikaParuchuri. I'm a 10th grader studying in New Jersey, United States. It's an honor to have you on my podcast. Today, we will be discussing how teenagers can maintain their health, because it's one of the most important assets that we can maintain for our age. Welcome to the Healthy Teens Initiative. Here, I'm trying to educate teenagers worldwide to take care of their health, and I do this by talking with experienced doctors like you so that we can reach this goal. Hello everyone, welcome to the Healthy Teens podcast. I'm here today with Dr.Mahati Priyadarshini, who is a critical care and pain management specialist who is currently the medical director at the Omega Hospitals. She has an experience that spans over 17 years and is one of the best intensivists in Hyderabad, India. Now, Dr. Mahati, would you like to introduce yourself?
Hi, Eshika. Hello, everyone. I'm Dr. Mahati, and Eshika has already given a kind introduction. So, I am a critical care specialist and also a pain physician in Hyderabad, and I've been practicing over 17 years. So, I would be really glad to clear all the doubts that Eshika has on behalf of the teenagers. Yeah, I'm ready.
So, let's start with what is critical care? And what is the primary goal of critical care management?
Okay, so critical care medicine is a super specialization where we see the sickest of the people in hospital. So when the patient is very, very sick with multiple infections or multi-organ dysfunction in the sense, at a time the patient's lungs are not doing good, their kidneys are not doing good, they are requiring support of mechanical devices to maintain their organs, then the patient comes to the critical care area. So the critical care medicine is all about aggressive monitoring. So how are the other units different from critical care? So when the patient is in an ICU, so they are continuously monitored by the doctors, by the nurses, and all the specialists who are coming in. So that is what the ICU is about. So unless the patient is very sick, they will not meet us. They don't come to the ICU.
Okay. And what are the key components of critical care assessment and admission to an ICU?
Okay, so there are multiple criteria to decide admission. Different countries follow different scoring systems, but overall, when the patient is sick and cannot be maintained in the wards with general monitoring, when they need 1:1 nursing care, they need 1:1 doctor's attention, is when the patient comes to the ICU. Suppose the blood pressure is very low and they're requiring medications to maintain their blood pressure, they need to be in the ICU. So there are multiple criteria to decide when the patient has to be in the ICU.
Okay. What are the types of shock and how are they managed in critical care?
Okay, so first, shock is a condition where the blood pressure is subnormal. So the blood pressure is lower than normal. So if we say 100/70 is normal blood pressure, 100 being the systolic and 70 being the diastolic blood pressure, when the blood pressure is lower than that, it is called as shock or hypotension. So there are different types of shocks. There can be cardiogenic shock where the heart is not pumping properly, and because of that, the body is not able to maintain certain blood pressure. Then there are distributive shocks. Distributive shocks in the sense where the blood vessels are fully dilated. So there is peripheral pooling of the blood and not enough blood is coming back to the heart. So this happens in severe infections so in that condition we call it as septic shock. Then there are hypovolemic shocks. Hypovolemic shocks in the sense where the blood volume is less in the body. So that could be due to acute blood loss as in trauma, or due to hypovolemia due to decreased intake. So the patient has acute gastroenteritis, they are vomiting too much or passing too many stools, and they are severely dehydrated, then they can have shock. So this is broad division of shocks. There are other criteria also to describe shocks, but these are the common: cardiogenic, distributive, and hypovolemic shocks.
Okay. What is the role of mechanical ventilation in critical care?
Okay, so mechanical ventilation, so it itself says, so when you are artificially ventilating a patient, ventilation means the role of lungs. So we breathe in and breathe out, we breathe in oxygen, breathe out carbon dioxide. So that is called as ventilation in our body. So when the patient has severe pneumonias or there is a big stroke in the brain and they are not conscious enough to breathe on their own, or they have lot of infection in the body and they don't have enough strength to breathe and supply adequate oxygen to the body, then we put a tube through their mouth into the windpipe, and then we connect the tube to a machine which is called as mechanical ventilator. So there are multiple criteria to put a patient on ventilator. It is basically to support the lungs and to deliver adequate oxygenation. Sometimes even though the lungs are good, as I told in strokes, in the brain strokes where the patient is not conscious enough, they can aspirate. They cannot even swallow their saliva, so that saliva can go into the lungs and cause infection. So even in those cases, we have to tube the patient and put them on ventilator. So there are multiple indications for putting a patient on mechanical ventilator. So basically it is done to prevent morbidity and mortality. Morbidity means to prevent damages due to not due to inadequate supply of oxygen, and also to prevent deaths. So that is how mechanical ventilator helps us.
Okay. So we have been talking about ICU from now, right? So what does ICU stand for, and what are the common complications dealt in ICUs?
Okay. So ICU full form is intensive care units. So these are the units where patients get intensive care. So intensive care is every hour, every minute they are monitored. They are connected to the monitors. So every second their heartbeat is monitored, their blood pressures are monitored, their urine output is monitored, and whenever there is a change in the normal change from normal parameters, we give support. Suppose the blood pressure is low, we add medications to improve their blood pressures. If the urine output has gone down or the patient is not making any urine, then we put them on dialysis to help them clear the toxins in the body. If they are not breathing enough, they are not able to take in adequate oxygen, then we put them on mechanical ventilators. So that is how we deal with different kinds of complications in the ICU.
Okay. What is the approach to end-of-life care in the ICU?
Okay, that's a big question. So end-of-life care has multiple components, Eshika. So I'll just give two simple examples because this is for the teenage kids. So end-of-life care in two scenarios. Suppose there is a 70, 80-year-old grandma or grandpa. They have lived a good life. Now they have come with some infection which has affected all the organs in their body. Now we are trying to treat them because infections mostly are reversible, but in elderly they are more difficult to treat, and when more organs involved, the mortality increases. And the family wants to do everything for them. But we know now there are grandmas and grandpas who tell that not to put tubes and lines in them and not to torture them and just prolong their life artificially. So there comes the dignity of the patient. So here it is the will of the patient. But again, when the patient is too sick to decide what they want, the family makes the decisions. So when we counsel the family, we always ask them to consider the wishes of the patient, because we should not overrule completely just because they are not in a state where they can express. Then there is this other component where suppose a patient has a cancer. Let it be a young patient or old patient, age is immaterial. They are in an advanced stage of disease. Everything has been done. We have tried everything. Then probably we should sit with the family and decide what best is for the patient. Because cancer is draining not only to the family, not only to the patient, but also to the family, emotionally, socially. So there are these are two different aspects to end-of-life care. So in end-of-life care, there is palliative care too. So when patient has an irreversible disease, we suggest palliative care where we keep them comfortable.
Okay.
We keep them pain-free. We see that they are not starving. We give decent nutrition, and they are kept comfortable. But we don't try to artificially prolong their life. So it is a complicated topic. I hope at least I have touched the tip of it.
Yeah. I was wondering, is an ICU similar to an emergency that works like 24/7?
Okay, that's great. Okay, both emergency department and ICUs work 24/7 because sick patients are continuously monitored in the ICU. Emergency department is the area where the patient is initially brought. So whoever is coming with, suppose somebody had a very high blood pressure, and because of that they have gone into a pulmonary edema, lungs getting filled with water because the heart has failed. They go to the ER. So in the ER, initial resuscitation is done. So we give medications to lower their blood pressure. If required, they are put on a ventilator, and then the respective departments are called. If it is a cardiac issue, the cardiologist is involved. Then emergency scans and echos are done, and then the patient is shifted to the ICU for further management. So emergency department is to deal and stabilize the patient at that moment, and then they are handed over to the ICU. But in the ICU, the patient is there until they get better and the issue is resolved, with which they came to the ICU, and then they go out to the wards and from their home. So both are 24/7 units only, but in emergency department, they are stabilized for that time and then shifted to intensive care units. In intensive care units, they have to get better and then go out of the ICU.
Okay. What is the role of nutrition in the ICU?
Nutrition is very, very important everywhere. So especially for the teenagers, it is more so important in the ICU because body is in hypercatabolic state. So the body is doing so many things. It is fighting an infection. It is trying to take all the antibiotics and help the antibiotics to work against the infection. Then there are so many other drugs going into the body, and the patient is immobile. When they are in the ICU, they are staying static on a bed. So there are so many factors which cause increased requirement of nutrition. So in ICU patients, we calculate calories, protein and fat according to per kg body weight, and then we try to give at least 80% of the calculated total nutrition so that the muscle wasting does not happen. We give adequate strength to battle the hypercatabolic state that they are in. So nutrition is a very important component. Actually, nutrition has been directly linked to mortality in patients. Mortality means we can bring down the death rate by giving proper nutrition in the ICU. It is that important.
Wow. That's very interesting. So let's talk about pain management. What is pain management?
Okay, so pain is a very broad word, isn't it? So to keep it short, pain is basically divided into acute, subacute and chronic. So acute pain is something, you're walking, you have hit a stool and your toe is hurting. That is acute pain. Somebody has undergone a surgery, so they have stitches. That is acute pain. And I sprained my shoulder doing some activity or while driving a car, that is acute pain. So we take over the counter medications for that, NSAIDs, paracetamol, all these drugs. So if that pain is lasting beyond 4 weeks, it has turned subacute. So anything between 2 to 6 weeks will be subacute pain. And more than, if the pain is staying for more than 6 weeks, it is chronic pain. So chronic pain has its own. In chronic pain, the pain memory stays in the brain. So even if the hurt is gone, the memory will still be there, and it is very difficult to treat chronic pain. So when you have acute pain and it is staying beyond a week or two, it is advisable to go to your doctor and get appropriately evaluated. So that is one categorization of pain. There are multiple categorizations of pain, but yeah, to keep it simple, you should know when you should be seeing your doctor.
Okay. What are the primary considerations that are taken into account when managing pain in elderly populations?
Okay, so in elderly, they don't come with the pain in acute state. So most of the times they have hypertension, diabetes and other long-term medical issues. So with diabetes, there will be neuropathies. So and there is also high risk of fractures in elderly, where they don't have manifestations like young people. Like elderly person has fallen down, they have broken their hip. They will not have as much swelling and as much deformity because the inflammatory response is not aggressive in elderly. So they have some difficulty in walking, but they realize it later, and then it becomes more difficult to treat. So when elderly come with pain, we have to keep in mind about the comorbidities that they have. And we have to keep in mind that most of the times it is chronic pain that we see in them. And we should always be more towards doing investigations in elderly. Because missed things are there. There will be hairline fractures which will be missed because the response is not as aggressive as it is in the young.
Okay. And let's shift to the other extreme of age group. How does pain management work in pediatric populations?
Okay, it is difficult because more pediatric kids usually cannot explain appropriately the degree of pain or the intensity of pain they are having. So mostly in kids it is acute pain only. They have some bug in the gut and they have gastroenteritis. They keep complaining of colic, or they have fallen. They have some trauma and they have injuries. So pain medication requirement is also not very aggressive in kids, and NSAIDs are very very good for kids because they work quickly and the relief is better in kids.
Okay. So now let's talk about how it is for you. What is the best part and the worst part of being a pain management and critical care specialist?
Okay, so critical care medicine and pain medicine are two different specialties. So I will tell what I love about being an intensivist. So I always wanted to be an intensivist. I decided it when I was in the final year of my medicine and I was posted in a ICU. So it is a kick that you get when you make a near dead patient walk out of the ICU. So you mostly receive people who come in a very terrible state to you.
Yeah.
So their organs are all damaged. They are not able to talk. They are on the bed. They are on multiple support systems. And when you treat such a patient and they go back to their families with a happy face, I think that is the best thing that can happen to you. So you don't need anybody to come and praise you. It's just that is the best pat on the back that you can have. And of course, the toughest part is to deal with the deaths that happen. So, however much you know, I think as a doctor, it is very difficult for you to absorb the fact that you have lost a patient. Probably that's the toughest being an intensivist. And coming to pain medicine, the best part of being a pain physician is many times the people keep going to different doctors. They keep going to orthos. They keep going to neuros, but the actual cause is not identified because the way we see pain is different than the other specialties do. So when we identify something that hasn't been identified by other doctors and we are able to treat, and with suffering that has been there for years, so many times they come with suffering that has been there for years and we are able to treat it, that gives a lot of satisfaction. And the frustrating part in pain is about some pain pathologies like fibromyalgia and stuff where you don't have a complete cure and the patient has to be managed with drugs and lot of counseling. So yeah, they are a little tough.
What is something that you have seen differently when you first started your practice in both pain management and critical care to now?
Oh, their medicine has been developing leaps and bounds, and I feel ancient when I compare the things that we were doing when I started my training. So now we have, for example, people with all gone lungs. We used to struggle with only ventilators, but now we have ECMO. We are more trained in ECMO. So ECMO is a artificial system which completely sends oxygen into the body and clears carbon dioxide where the ventilator is failing. So we put people on ECMOs and they stay on ECMO for some time and then they get weaned to the ventilator and then they come out. So probably 15-20 years back, I couldn't have saved that patient, which we are able to do now. So this is just one example. There are so many more devices. There are so many cardiac devices. There are so many transplants happening. Let it be kidney transplant or liver transplant, which are happening very commonly now, which were not like that 15-20 years back. So yeah, there are so many advances even in drugs, pharmacology. We have got so many more new drugs with lesser side effects which are helping people survive, and this is openly reflected with the longevity of people, how people are surviving longer, even the antibiotics. But again, the downside is we are seeing more resistant infections. The bugs are becoming more resistant because of the rampant usage of antibiotics, and also improper care taken by people. You have to care for yourself to prevent yourself, and prevention is always better than cure. So yeah, and coming to pain medicine, there are a lot of interventions which are happening now, like There are endoscopic surgeries. We are using radiofrequency ablation for nerve pains more often. So yeah, it has changed leaps and bounds.
That's very nice. Could you tell us about, maybe you've seen probably many cases, but could you tell us about an interesting case that you have dealt with in both critical care and pain management?
Okay, so in pain medicine, there was this young guy who had lower back pain for almost 4.5 years. And it came to a level where he was not able to do his day to day activities. He was depressed. He was having issues in his marriage. He underwent multiple scans, he met multiple doctors, but his issue was sacroiliitis. So sacroiliac joint is a joint in your hip, which is difficult to show on scans. It is clinical examination that makes the difference. So after identifying the condition and treating it, he was so happy. His life changed completely. So this is one interesting case. There are so many more, but I connected with him so much because he was a young guy and this pain was affecting not just physically but also socially. He was not able to, he was isolating himself from people. He went into depression. So that is one case. And if we start talking about ICU, probably I'll take the whole day. So yeah, I have this elderly lady. I'll talk the freshest now. Elderly lady in my ICU. I think she is my cutest patient now. She is 86 and she came with a lung infection. So pneumonia in elderly people beyond 70 years of age has a mortality of 80%. So 80 people out of 100 don't make it. But this lady is so strong-willed that she came off ventilator in 3 days. She's sitting in the chair and she's so zesty that she's demanding things. She tells, "Why are you not giving me enough food? I am hungry," and all that. So yeah, this makes us really happy when people come out like that.
That's very nice to hear. So, do you have any other advice that you would give to teenagers who might not care about their health too much, right?
Okay, so I think teenagers have become more aware of things nowadays. So teenagers are definitely more evolved than what they were few years back, probably because of all the information they are getting from internet. But again, the downside is that the information is being misused too. So probably drug addictions and screen addiction. I would say screen addiction is even more worse than drug addiction. We think that screen addiction is affecting only our eyes, but it is causing so many other. The incidence of hypothyroidism has increased because of screen addiction in kids. Can you believe it? The endocrinal glands getting affected because of extensive screen time. So it is to that extent. We don't even think about those things, isn't it? And then I would really request the teenagers to be more alert towards the elderly in the home, because our youngsters' parents are working. Probably they cannot give that much time to the grandparents at home. So maybe you can just say hi every day to them to see if everything is okay with them. So this way you will keep them happy and you can also take care of yourself. Yeah.
That's a good word of advice. So, could you tell us what inspired you to become a critical care and pain management expert?
As I told you, when I was posted in the final year of my training in ICU, I really saw how sick patients were going out. Just monitoring. We don't do anything extraordinary in the ICUs. It is all about monitoring and doing the right thing at the right time. So it made the whole difference. So it is between death and life. So if you give that care, a person who is going to be dead can become alive, stay alive, and then go out of the ICU. Yeah, probably that is the first day in the ICU, I decided that I was going to be an intensivist. Pain happened during my MD training. So during my MD training, I saw so many patients with back pain who could not undergo surgeries. Then again, we see patients with knee pains who are old enough or with too many complications who are not able to undergo surgery. So they have an option to undergo a pain intervention and be relieved of the pain. So that motivated me to pursue pain. And also, pain management is a significant component in critically ill patients. It is very important to keep them pain free with all those tubes and lines when they are there in the ICU. So yeah, every day is a challenge and every day is interesting.
Okay, so now we will move on to our myths section. Let's go through some common myths that might appear in both of these areas of medicine. Firstly, pain does not affect short and long-term outcomes.
Oh, that's absolutely false, because pain does affect short-term and long-term outcomes. Because if acute pain is not treated appropriately, it will convert into chronic pain, and chronic pain is very difficult to treat because it is not just the local injury that is causing the pain, but it is also the memory that is there in the brain, and more drugs are required. It takes longer, and it turns into a syndrome where not just the organ is involved, not just the part of the body is involved, but other parts also start getting involved. So it definitely affects. If you don't give adequate attention, then it definitely affects the outcomes.
Okay, the majority of critically ill patients receive adequate pain control.
Majority of the patients in the ICU, yes, they do get adequate pain control, at least in my setup, because it is very difficult to monitor pain scores in patients who are sedated and already on ventilators. So here we have to rely on their blood pressure, their heart rates, and if they are grimacing in between. And we have scoring systems again to maintain the sedation levels. So how to optimize the drugs that are being delivered to the patients. So yes, yeah, we are doing fairly well in maintaining the keeping the patients pain free in the ICUs.
Okay. Pain control in the ICU is primarily the nurse's responsibility.
I wouldn't say primarily the nurse's responsibility, but yes, it is majorly the nurse's responsibility, because they are there on the bedside continuously, and they have to do the pain scores every hour. So, which needs to be monitored by the doctor too. So, I wouldn't call it a myth, and at the same time, I wouldn't say that it is totally appropriate, but yes, it is majorly monitored by the nurses.
Okay. Opioids are all that is needed for effective pain control in the ICU.
No, that's a myth. So opioids are taken as a last resort. So if the patient a patient is intubated on ventilator, then probably we use short-acting opioids for infusions, and then we switch to other forms of drugs as soon as possible.
Okay.
So they are not the only modality used in the ICU.
Okay. Elderly patients experience less pain than non-elderly patients.
Elderly patients experience less pain
Than non-elderly patients.
That's a myth. So elderly have it has nothing to do with elderly and non-elderly, actually. Pain sensitization, because pain perception is an individual response. So some are hypersensitive to pain, and some are quite tolerant to pain, and it usually does not have much to do with age. But yes, we can say that younger population are hypersensitive, than rather than saying that elderly population are less sensitive. So yeah, that's a myth.
So that has now concluded our podcast session. Thank you so much for being on my podcast. It was an honor.
Thank you, Eshika, for having me. It was really nice interacting with you.
It was very nice. I think we have uncovered more information about critical care and pain management. I think it might be an underrated branch of medicine. At least for me, I didn't know much about pain management. Thank you so much for your time, inputs, and contribution. And for our viewers, we have a slogan from our doctor.
Okay, so nourish your habits to flourish your lifestyle. Stay healthy.
Thank you.
Thank you.